So our lesson for today is on the cardiac panel. So the learning outcomes for our lesson for today is to basically discuss about the importance of our basic cardiac markers. Okay, so we'll be talking about what they are, and is it a sensitive biochemical marker or is it a specific one? Okay. And each of these markers have their own timing. Okay, so we need to know if this marker is the right one at the right time. Okay, and what is the prognostic value? So for example, if you're given a cardiac marker, is it something that will tell us if there is another cardiac event coming? Okay, so let's start. So when we're given a patient who's suffering a heart attack, especially at the ER, okay, we as physicians, aside from the proper history taking and the PE, would like to ask some help with the aid of some cardiac markers, right? So and other modalities as well. Okay, so what are the laboratory tests that you would order on a patient suspected of acute myocardial infarction? What is the single most important laboratory test for the diagnosis of acute myocardial infarction? What are the expected trend of results of a cardiac panel test given a cardiac situation? What is the prognosis based on the results? Okay, and the assessment of a patient having chest pain. So of course, as a doctor, you'd like to have, aside from the proper physical exam and the history taking, of course, we would like to also get the right person to interview, because you would definitely, when the patient is in pain, the patient will not be the best one to ask. So if the patient has a significant other at the scene of his suffering, then the best person to ask is the significant other. Okay, so here I flashed some of the modalities that are used to assess chest pain. Okay, we have the ECG, coronary angiography, echocardiography, and nuclear imaging. However, these modalities, although sophisticated, okay, of course, sophisticated compared to our usual history and PE, but these are but nothing takes place of the right and the proper history taking and PE. Okay, so although sophisticated, these modalities have their own limitations. Okay, and nothing takes place of the properly timed and use of these assessment of the serial rise and fall of the cardiac biochemical markers, especially when we are dealing with myocardial infarction or necrosis. Actually, it is the most clinically relevant. Okay, let's go back to our lesson in general pathology. When we talk about acute coronary syndrome, it's either we are just talking about stable angina, which is chest pain when the patient is exercising. Okay, unstable or with effort. Okay, that's stable angina. And when we are talking about unstable angina, it is chest pain when the patient is at rest. Okay, so even at rest, the patient is having this chest pain. Okay, and the third one is acute myocardial infarction, where we have the heart of the patient has already diminished blood supply, okay, leading to infarction or poor blood supply of the heart. Then next we have sudden cardiac death, wherein we knew that it is a consequence of ventricular fibrillation or atrial fibrillation. Okay, so whether there is a presence of an infarction or not. Okay, that is sudden cardiac death. And this acute coronary syndrome is a consequence of atherosclerosis. We already know that, and leading to ischemia and infarction. Okay, so acute coronary syndrome can be assessed through electrocardiogram, wherein we are looking at if there is an ST elevation, okay, or a non-ST elevation, okay, and aside from that, we also use biochemical markers, or what we call cardiac markers, okay, and when it is positive, especially the markers that I'm talking about here, I'm pertaining to troponins, creatine kinase, and myoglobin, and we also have LDH, okay, which these are the most common cardiac markers used in the laboratory. Okay, so electrocardiogram, cardiac markers. But when the cardiac markers are already positive, okay, these are positive, these already rule in myocardial infarction. Okay, so whether or not it is an ST elevation, there's an ST elevation or no ST elevation, so there's still myocardial infarction if the markers are positive. Okay, and most commonly ST elevated MI, okay, will lead to what we call as Q-wave MI, okay, and Q-wave MI, by the way, you will learn this in third year, means that there was a previous MI, an old infarct. Okay, non-ST elevated MI means that there's a majority means that there is a no previous infarct, but in some cases these can be interchangeable. Okay, so by the way, when you say non-ST elevated MI, it means it's another term for subendocardial infarct, and we learned this in our gross pathology lecture, that subendocardial infarcts only affect part of the wall of the atrium or the ventricle. In contrast to ST elevation MI, this is another term for transmural infarcts, where you have the whole wall being affected by the infarction. Because the goal in our lecture here is to be able to single out acute MI, okay, the importance of these markers, okay, is to be able to tell that there is an acute myocardial infarction. Okay. However, you have in other conditions such as non-acute MI ACS, okay, such as when you have unstable angina or you have ventricular fibrillation, okay, these markers which will be used, which are used in detecting myocardial infarction, may not play a good role. In acute myocardial infarction, the evidence is based on the following. You have cardiac markers, you have ECG tracings, and you have autopsy and radiologic findings as well. So the cardiac panel that I'm talking about since the start includes the following. Please take note the first three, okay? Troponin, creatine kinase, myoglobin, lactate dehydrogenase, aspartate transaminase, beta natriuretic peptide, C-reactive protein, ischemia modified albumin, aldolase, and unbound free fatty acid. So what happens if you notice these components? These are actually components that are being released from muscles, okay? Especially here from the cardiac muscles. So remember troponin, remember creatine kinase in glycolysis, remember myoglobin, which is it's a pigment, it's also an enzyme, okay, from the muscles, and what have you, okay? So these are enzymes, these are proteins that are released from damaged muscle cells, especially those from the heart. Troponin. Okay. These are groups of enzymes or proteins involved in muscle contraction. Okay. It can be either troponin T, troponin I, which actually is the most specific for acute myocardial infarction, and troponin C. Within the first 4 to 8 hours, there is immediate release of cytoplasmic troponin from the infarcted cardiac muscle. Within 10 to 14 days, there is sustained release of bound troponin. So this is probably why troponin, especially troponin I, is considered as the most specific marker for acute myocardial infarction, because the levels of troponin when there is myocardial infarction maintains, okay, elevates in as long as 2 weeks. However, in rare instances, aside from acute myocardial infarction, there may be increased levels of troponin in the following situations: when you have cardiac contusion and myocarditis. But it is definitely not elevated in skeletal muscle injury or in vigorous exercise. So where is the troponin here? What is this? This is the actin. This is the myosin. This is the yellow one is the troponin. Okay, that is the mechanism of muscle contraction. And troponins have high specificity for acute myocardial infarction, even with just one positive result. However, there is limited sensitivity. Okay, but when you have repeated testing and you have a consistent negative result, okay, that means that it is that heart attack is absent. Okay, so increasing levels of unstable angina patients indicate increasing levels in unstable angina patients indicate progression to acute myocardial infarction. Okay, so the words that you'll be meeting here in our lesson will be words that are used in public health, okay, such as specificity, sensitivity. We might be wondering what these terms mean. Okay, specificity means that to simply put it, specificity, when the test is highly specific, take note. Okay, you have a highly specific test. When it is positive, it rules in disease. Okay, when a test is highly sensitive, when it is negative, it rules out disease. Okay, that is simply speaking. Okay, so let's go back again. When highly specific, so that means when troponin is positive, you have definitely that will tell us that there is acute myocardial infarction. When troponin is negative, okay, that does not tell us that there's absence of myocardial infarction. But when you have repeated tests and the test is consistently negative, then that means that there is no myocardial infarction. So that's how to explain this slide. Okay, so the next biochemical marker is what we call as creatine kinase. No, it is an enzyme that phosphorylates ATP. Okay, so or adds a phosphate group. Okay, so isoenzymes, the creatine kinase exists in 3 isoforms. You have creatine kinase BB, which is the source of which is the brain. However, small amounts are found in the bladder, stomach, and prostate. And it is the fastest isoenzyme, okay, because these isoenzymes are measured in electrophoresis, okay. Next is CKMM, okay, which is produced mainly by the skeletal muscles and minority by cardiac muscles, which is the slowest. Next is CKMB, which is produced majority by the cardiac muscles. Okay. Abnormal forms of CK exist, however. These are in the following forms. You have macro CK, which is what they call as CKIG, okay, which is found in elderly women, healthy elderly women, and mitochondrial CK, which is found among patients that have advanced disseminated cancer. Creatine kinase is elevated in the following situations. You have acute myocardial infarction, a genetic muscular disease, which such as Duchenne muscular dystrophy, strenuous exercise, even stroke, okay, non-ischemic cardiac events such as pericarditis and myocarditis, and also we also have a false positive when you have hemolysis, okay, due to the phosphorylation reactions that is also produced by the red blood cells, okay. It has, however, no specificity for acute myocardial infarction, and we have increasing sensitivity with serial measurements, such just like troponins. When troponin I is elevated, we also see that serial CKMB measurements may show increasing in levels, okay. That means that there is acute or extension of infarction, or decreasing levels, which means that there is resolution of infarction. The third enzyme, okay, or biochemical marker that we'll be talking about is myoglobin, okay. It is an enzyme in glycolysis, okay. Very much similar to creatine kinase. It is released from a damaged muscle, okay. So, and it is highest sensitivity for acute myocardial infarction because it is the earliest marker for acute myocardial infarction and should be expected to be elevated when the patient is presented at the ER, and least specific for acute myocardial infarction. The assay used in the measurement of myoglobin is what we call as rapid immunoturbidimetric method. Normal myoglobin within 2 hours from the symptom onset can exclude acute myocardial infarction, okay, because of its high negative predictive value. However, the drawbacks is that we cannot isolate cardiac myoglobin from skeletal muscle myoglobin, and it can be elevated in non-muscular disease such as renal failure and severe systemic diseases. So again, the triple combination, okay, is considered as the best marker for acute MI diagnosis. So in reality, these three markers are the ones included in the cardiac panel, okay. The rest of the markers may or may not be included, but these three are the most important. So again, you have troponin, CKMB, and myoglobin. So troponin being the most specific and myoglobin being the most sensitive. So comparing the three, okay, cardiac troponins increase as early as 3 to 4 hours, and it remains elevated for as long as 2 weeks. That's why aside from being specific, as it comes from the heart, okay, heart muscle, it is a cardiac marker that becomes elevated, remains elevated in as long as 2 weeks. Next is we have CKMB. Okay, it starts to increase 3 to 6 hours after a heart attack, and it peaks in 12 to 14 hours. And it remains elevated as long as 3 days. Okay, and it goes down after that unless there is a new or continuing damage. Myoglobin starts to increase 2 to 3 hours after injury and peaks in 8 to 12 hours. And it becomes elevated, okay, within 1 day after injury. After that, it goes down. This is a very important slide comparing the three biochemical markers. Okay, you have myoglobin, which is the one that starts to elevate first. Okay, next is the CKMB. Okay, next is the troponin. Okay, so we are talking more specifically about troponin I. So the next biochemical marker that we'll be talking about is lactate dehydrogenase. It is an enzyme that catalyzes oxidation of lactate to pyruvate. Okay, still involved in glycolysis. Isoforms, it occurs in these isoforms. You have LD1 coming from the heart or the RBCs, which is the fastest. LD2 coming from the kidney, which is the supposedly normally highest in concentration. LD3 from the lungs, LD4 or 5 from the liver, and LD4 and 5 from the skeletal muscles. And when you have a normally LD2 has to be elevated compared to LD1. Okay, however, when you have a flipped pattern, such as you have a higher peak of LD1 compared to LD2, that is where myocardial infarction is diagnosed. Okay, so in other situations where LDH can be elevated, you have pulmonary embolism, liver disease, muscular dystrophy, hemolytic anemia, acute lymphocytic leukemia, and hemolysis of the specimen, such that specimen is advised to remain at room temperature. LDH begins to rise within 12 to 24 hours and returns to normal within 10 days. The next biochemical marker is an enzyme again, okay, and it is produced by a lot of sources, okay. So you have the heart, liver, skeletal muscle, and RBC. So we're talking about aspartate transaminase, and this enzyme is also important in detecting inflammation from the liver as well as inflammation of the heart. That's why it's really not that specific. Okay, so you have elevations in cases of acute myocardial infarction, liver disorders, muscular dystrophy, and it can be false positive in a blood specimen that has undergone hemolysis. In acute MI, it begins to rise within 6 to 8 hours and peaks at 24 hours and returns to normal within 5 days. Beta natriuretic peptide, this is quite very familiar to you, okay, because it was mentioned in the regulation of blood pressure, okay. It is a peptide that causes vasodilation and natriuresis, okay. It is secreted from the ventricles in response to congestion. Okay, when there is already congestion from the heart, secondary to fluid overload. Okay, perhaps secondary to a heart attack, or with or without heart attack. Okay, there is congestion. Okay, so there are three types of natriuretic peptide. It's either you have A and P coming from the atrium, B and P coming from the ventricle, or C, which is a less studied natriuretic peptide. And BNP is elevated in cases of heart failure. Okay. However, it can also predict, okay, future a possible episode of heart failure after an episode of myocardial infarction. Okay, so it differentiates cardiac from non-cardiac causes of dyspnea. The normal level of BNP is less than 100. Okay, so anything above that is stated as what you have seen in the slide. C-reactive protein in general is a marker for inflammation. Okay, it's a marker in response to inflammation. And what it does is that it binds to lysophosphatidylcholine expressed on the surface of dying cells. Okay, and after binding, it activates complement. The source of this CRP, okay, is from the liver, and it is a strong predictor for ACS development in healthy individuals. Okay, HSCRP is a more sensitive kind of CRP. Okay, it can also be called as a heart-specific CRP. Okay, why is it more sensitive? Because HSCRP assays are capable of measuring serum CRP to as low as 0.6. The normal level of HSCRP is less than 10. Okay. However, in cases above where you have HSCRP above 10, then it is used to predict recurrent cardiac events. Okay, so this is when you have the patient is undergoing some unstable angina 6 to 24 hours after symptom onset. So you have BNP and HSCRP. Again, BNP is used to determine if there is a possible heart failure. Okay, HSCRP is used to determine any. It is a inflammatory marker. Okay, especially it is more specific for the heart. Okay, and it predicts future cardiac events. Next is albumin. Albumin from the blood is being affected, okay, when there is ischemia or infarction. Why? Because in normal cases, albumin used to be tightly bound to a mineral called cobalt. However, in acute myocardial infarction, where there is a increase in acidity in the blood environment, or a low oxygen or high calcium, and you have increased release of free radicals, then the albumin has a reduced cobalt binding capacity. Aldolase, again, it is another enzyme involved in glycolysis. Okay, the sources of which are almost all body cells. That's why it's never specific nor sensitive. Okay. And you have clinical significance. You have, or it's elevated in acute MI, muscular diseases, progressive muscular dystrophy, okay, which is highest in this case, and also false positive in an hemolytic specimen. In cases of MI, it rises in 6 to 8 hours and stays up to 3 to 4 days. And also, free fatty acids are being expelled in the blood, okay, in cases of infarction. And we are talking about omega-6 and 9, which is found in the blood, okay, and it's elevated in cardiac infarction or ischemia. Okay. So we're done already with cardiac biochemical markers, cardiac enzymes. Okay, and just to mention, there is this event called washout phenomenon, or what we call cardiac reperfusion. And how do we know that there's already perfusion of blood in the cardiac muscle? Indications of successful reperfusion are the following. You have all cardiac biomarkers peak earlier than normal. The sequence of peaks parallels that of the normal MI. However, the peak concentrations may be higher than in the unperfused MI. Okay, still the same sequence. Okay, still the peaks, same sequence, but the peaks are earlier than normal. And in assessing myocardial infarction, the risk for myocardial infarction, okay, are being assessed by the following tools. Okay, first is what we call as the GRACE assessment. It's a acronym for Global Registry of Acute Coronary Events. Okay, it makes use of risk factors. Actually, what happened here is that in the development of this tool, there is a tally of different cases of myocardial infarction, and they were able to take note that the risk factors of myocardial infarction are dependent on the following. You have the age, you have the pulse, you have the systolic BP, you have the creatinine. Is there a cardiac arrest at admission? You have ST segment deviation. Does the patient have abnormal cardiac enzymes, or is there a presence of heart failure? And by that, it can be assessed if the patient is having a low risk for MI, future MI, medium risk for MI, or a high risk. Another tool that can be used to assess a myocardial infarction risk is this one. This is a thrombosis in myocardial infarction. So it is a assessment it's an assessment tool. Okay, it is a scoring tool. That's again, that makes use of risk factors such as, is there a presence of what's the age of the patient? Is there presence of comorbidities such as diabetes, okay, or presence of hypertension and angina? What's the BP, heart rate, the weight of the patient? Is there a presence of heart failure? Okay, was there a presence of a prior blockage in the coronary artery? Okay, and other risk factors as well. However, comparing GRACE, risk assessment, and TIMI, GRACE is more predictive of MI. Okay, nowadays other tools also exist. Okay, so but I'm just presenting to you two of those tools that will assess us about the risk of a patient for future MI. And thank you very much for listening to my lecture.